Good to see you.
Thank you for inviting me to this beautiful place. My topic is going to be slightly different from what was discussed. If we have to assume that this patient has only mild coronary artery disease, we're going to talk about something completely different. So I'm not going to bore you with any more Kaplan-Meier curves. There'll be no tables, there'll be no slides. There'll only be a story of a patient. Before I start, I just would like Dr. Handel's comment about Diamond and Dr. Forrester, both of who are my mentors. And I respect those people immensely. And even though their terms have slightly changed, those three terms, typical, atypical, and non, will always be there. They taught us the Bayesian analysis. Diamond has died a few years ago because of cancer, and Jim Forrester is very frail now. But I consider him as one of the greatest mentors in my life, and for many people here. So this is a 38-year-old female who presented with ejection fraction with severe shortness of breath and coughing and racing heart. And she was treated for pneumonia as expected. Of course, nobody used a stethoscope in those days. So she was treated for 2 months till she became acutely short of breath and presented in a hospital almost dying. When she was taken to the hospital, she was hypotensive, she was tachycardic, she had bilateral crackles in her lungs, and she had bilateral pedal edema. She was taken to the cath lab, and the chest x-rays are the following findings. Over here, you can see that her ejection fraction was 18%. She had a dilated ventricle, and she was started on IV diuretics. And this is what her before that, diuretics. And then she was told that she probably they did a cath immediately, and she had very mild coronary artery disease, just mild non-obstructive disease, when the EF was terrible. They put her on inotropes, then they tried to start her on low-dose Entresto, and she crashed. So then they still kept her on some low-dose inotropes. She remained tachycardic, very short of breath, and then they called me and said, Saibal, can you do something for her? So she was transferred for the hospital on these drugs the next morning, actually 4 days later. And this is what her chest X-ray looks like. And the first thing I noticed in the examination that she was weak but not in distress. Her heart rate was 100 and her blood pressure was 95/60. And there's a reason why I'm saying this. She was weak and not in distress. So she was, and if you look at that chest X-ray, it clearly shows that she's euvolemic. Clearly she's not in pulmonary edema. She had a grade 3 holosystolic murmur with a soft S3 and an accentuated S2. She was on an IV Lasix strip and a low-dose dobutamine. And she continued, as you can see, as tachycardic. And you can see over here, the EKG demonstrates evidence of left ventricular hypertrophy, no ST elevation, ST depression, no abnormal QAs. Obviously, I realized that this heart disease was not 2 days old. It was at least a few months because this was signs of an enlarged ventricle. This was the echo that I did at the bedside when she came in. This is on inotropes, is on a Lasix strip and euvolemic. And you can see over here, this is a ventricle which is hardly moving, which is a ejection fraction of 18%. And actually the volume you can see over here, and the numbers are the LV end systolic diameter was 6.5 and diastolic was 7 something, EF of 18% with severe functional MR. The ERO calculated was 0.5 and was mild TR. And I called Dr. Joe Wu up and he says, don't call me. And he said, I always like referring cardiologists. So anyway, so he always says yes. And you can see here the valve area is normal, 5 square centimeters, and the jet is central. So the question is, what do you do with such a young person, and what is the diagnosis? My diagnosis, therefore, was acute on chronic heart failure with reduced ejection fraction. My chronic with being chronic is that I think she was misdiagnosed as pneumonia for a few months. She basically had dilated cardiomyopathy, probably related to some viral illness, and it was acute presentation. She was in refractory congestive heart failure by definition. She was still on IV meds, so she's class 4D. She's non-ischemic dilated cardiomyopathy, and she has severe functional MR. So I think most people in this audience would agree with that diagnosis based on those findings. If there's no, the question is what's next? Does she get evaluated for LV assist device and transplant status 1A? I'm sure Dr. Jubu would take my call with that. He said yes. Consider insertion of impella in a balloon pump. Consider high-risk mitral valve surgical repair. Consider transcatheter edge-to-edge repair. How many for the first choice? Consider her for device transplant status 1A. I'm in a symposium with Stanford. Stanford was the beginners of transplant. Okay. Okay, you would say that, right? Joe, what do you do? Yeah, would you? So you saw what optimal medical management she is on, right? She's on IV diuretics and she has become euvolemic. You saw the X-ray, okay? We've done that. She could not tolerate any dose of Entresto, so we tried that. She's still tachycardic. What else would you want to do in medication-wise? In a patient who's in inotropes, in shock, in acute setting, I never heard of a study on that. Have you? Okay. Patients dying acute SGLTs don't really work, really.
Saibal,
So
did she get a cardiac MR by chance just to look if there was extensive scarring or fibrosis within the myocardium?
no, we didn't do that actually, and I think there is a role for doing that. I agree with you.
I say this only because I would also lean towards an LVAD or transplant for her, but the recency of it is it's so contemporary, it's so recent that maybe there is an opportunity for LV remodeling and repair, or recovery rather, and yeah, and so that makes maybe a second decision for me of this list.
So let's assume we did that, and there was a lot of scarring. What would you do then?
Then I think it might be worthwhile thinking about
For
transplant LVAD candidacy.
Okay. So, so I had an assumption, of course, I didn't do an MRI, but I agree with your plan. I did notice that the valve was dilated. I did notice that it was not thick, and I did notice that the EKG showed high voltage, a lot voltage, suggesting that it's chronic. But I didn't know whether it was viable or non-viable. But there was no coronary disease. So you would consider that. You would not consider impeller balloon pump. Would you do that and then get SGLTs? Like, try medications by putting an impeller? Right. Would you consider mitral valve surgical repair? So I totally agree with that plan, that we would have to optimize this patient to the maximum capability, correct? I think everyone agrees with that, maximum capability with medications, if necessary, support system. And I think they did it in the sense that they did start him on IV diuretics, which actually helped the patient. They actually then give low dose inotropes. Then they also tried afterload reducing agents. They also tried small dose beta blockers. They actually tried everything. So they did it appropriately in the correct way. And this is like 7 days. This is, as you can see, she came in second. This is 14th day, February 14th. So they're actually on like 10 days. And this patient cannot leave the intensive care unit. Now, the reason why I brought this case up is that this patient, by definition, therefore, if he's almost 2 weeks out, is in refractory congestive heart failure, correct? Unless we go into something more. Unless you agree that they didn't treat him properly, like they didn't give him, I don't think they do it. So the patient does not fill COAPT trial conclusion. Do you agree with that? This patient would not be enrolled in the COAPT study. She's class 4D, that was an exclusion. Her EF is less than 20%. Now, what are the factors that favor considering edge-to-edge repair in this patient? One is the mitral valve orifice was large. It was greater than 4 square centimeters. Second, the regurgitation was from the middle of the valve, not very large. Third, the leaflets were mobile. You can see they're moving. And third, there was a small gap in the anterior posterior leaflet. So I said, what do you have to lose in actually trying a clip? And it still doesn't remove her from the option of a transplant, LVAD. So I actually told her that. I started by telling her that. She's only 38 years old. This is not going to be her final treatment, but we need to go further if she comes with. So what we did is the treatment plan, she appeared to me at least euvolemic. She was transferred directly to the cath lab. When I saw her, I saw, okay, because she came from another hospital, so that's all. And I said, okay, I won't even do a TE. Would you do a transcatheter echo? You wouldn't, right? Not in? Not necessary. So you think the anatomy is reasonable for you to just proceed? So we did that actually. We took her to the cath lab, we intubated the patient. As soon as we intubated the patient, the blood pressure crashed again. So we had to give her starter inotropes. And then we did a transcatheter echo on the table in the hope that we would consider edge-to-edge repair. So, and the most important thing is no balloon pump, no impeller. And I say this because there are very few procedures that we can do in cardiology with an EF of 18%, either high-risk PCI or TAVR, where we can do without any support. So here you can see that this is a patient whose EF is terrible, ventricle is large, and you can see that there's central mitral regurgitation, and the posterior and anterior leaflets come together and are very mobile. And on the right side, you can see that over there in the surgical end face view, you can see that there's leakages right from A2P2, sparing the sides. So based on this, I felt that this patient could be a candidate for edge-to-edge repair. We got femoral venous access. We had no balloon pump, as I said, no inotropes, and only a right radial arterial access to blood pressure. So this is the first clip. So we used MPR imaging, multiplanar reconstruction imaging, which I think Manny will tell you more about. But I think it's a nice way to exactly position it. Because it was a broad jet, I decided to put the first clip on the medial side of A2P2. And you can see what I've done by doing so is that I've lateralized the jet. So you have no medial jet, only a lateral jet. And you can see that as soon as you put the clip on, the blood pressure improved. The mean gradient was 5. And I said, wait a second, what do I do now? Should I move the clip and put it in the middle, or stop here and leave with little MR? But then I measured the valve area by planimetry, and I found the lateral orifice was 2.7, the medial orifice was 1. That means some of the gradient was coming from the residual MR. So therefore, I deployed that clip, and then we went ahead and put a second NTW right close by. You can see there's a residual jet, and then this clip is going right in the middle, and that's what you're left with now. Mild MR with 2 jets on either side. You can see a nice tissue bridge between and the entire A2P2 are caught. And then if we see on the lateral medial orifice, there's a small jet in between the 2 clips. There's hardly any jets on the lateral medial side. The mean gradient is 5. There was a significant improvement in the blood pressure. The blood pressure, which was in the 90s, became immediately 120. And there was improvement of the pulmonary venous flow pattern by echo. You can see it was severely systolically blunted. It now actually improved. And then finally, this is what I like the best is see, I usually do a pigtail catheter in the left atrium. You can see this is on a blood pressure of 90 systolic, a LA pressure mean of 27 with a V of 40-45. And immediately after 2 clips, actually, you can see that the A and V waves are equal, and the mean LA pressure has dropped from 27 to 17. So there you have an increase in blood pressure, you have a decrease in left atrial pressure. It is always a good sign. So personally, I think the reason why mitral actually works is because of this, is that there's actually an acute hemodynamic improvement. The patient was extubated on the table. When the patient had a dramatic improvement in symptoms, he was sent back to that hospital. The previous hospital, she was discharged day 4. And in order to get full disclosure, I actually called her yesterday to see how she's doing. She had come to my office last week. I said, listen, I'm presenting your case. I need to tell you, I need to find out how you're doing. So she actually says that she's, of course, asymptomatic at rest. She does have some shortness of breath on moderate exertion. Her EF has still remained 20%. And that's very important to show that it doesn't usually change. There's mild MR and the mean gradient is 5. And now she is on treatment. And that's the most important point, that when you treat these patients on mitral, they can tolerate GDMT. And so now she's on valsartan sacubitril, she's on metoprolol, she's on spironolactone, and she's on low dose furosemide. So you see, that's the key, that a patient who could not tolerate any of these medications now is on full doses of she's not on full doses actually, she's still on low doses, but she's tolerating it. She also, because of her low EF, has a subcutaneous ICD placed a month ago. So with that, I just want to say that, and I'm now opening it to questions. Transcatheter edge-to-edge repair adds years to life and life to years. This was an editorial that I wrote at Jack. It is safe and effective even in patients in class 4 heart failure. This was not done in the QUAD trial. And with reduction of MR and improvement of blood pressure, patients can tolerate medical therapy. And this is actually what was seen in the QUAD trial. That if you see the QUAD trial, if you look at the medication list, you will see that there was an increase in beta blockers in patients who underwent the clipped at a subsequent follow-up because they tolerated it, went up higher. And then finally, this can help in both delaying the need for a destination heart transplant or LVAD device, either delaying or even sometimes not needing it. Thank you very much.